Welcome everybody to the Optimising Prosthetic Outcomes by Looking Above the Leg webinar. This week we're focusing on lateral pelvic shift and weight bearing. The aims of the Optimising Outcomes series are to provide practitioners with techniques to enable their clients to gain improved functioning on the prosthesis, and also to facilitate communication between allied health professionals regarding their training goals and techniques to keep us all on the same page to improve the outcome for our clients. These webinars were designed for clients specifically in the low to moderate activity categories, including primary amputees, elderly amputees, K1 and K2 classifications, those who are using a prosthesis for transferring, people who are mobilising around their home, or those using walking aids. Although today's webinar can equally be applied to those in the K3 and K4 classification and using higher levels of technology, which respond better to increase lateral pelvic shift and weight bearing to get more out of the componentry. And we'll see that as we progress through today's webinar. If we think about weight bearing and lateral pelvic shift in amputee gait, if it's absent, we will see certain gait deviations appear. We will see a person who has lack of confidence in their prosthesis. There will be a propensity towards back pain due to the gait deviations that are produced. There will be overuse of the intact side and an inability to use prosthetic componentry correctly. If these components are present within the gait, we will see an optimal efficient gait, someone who has confidence in their prosthesis and can weight bear optimally on it. We will see optimal use of componentry, so we will see maximum return of energy from energy storing feet, and we'll see appropriate disengagement of stance phase resistance in MPKs. We'll see a decreased load on the intact side and an avoidance of back pain. I'd like to get you all to do something now, a little experiment, if you will, in the webinar. So please stand up. We're going to discover what happens if the pelvis doesn't shift to the stance side. So if you can all stand up for me, place your hands on your iliac crest. Now, without moving your pelvis to the left, stand on your left leg. Can anybody do it? Often I see when I'm delivering this in person that people have a lot of difficulty and tell me that it can't be done. It can be done if you shift your weight using your upper body, and this is called lateral trunk bending. So I'm hoping that you did that little experiment and can see that the only way to stand on one leg without shifting the pelvis is to shift your weight with your shoulders. And so this causes the most common amputee gait deviation that we see in the clinic, which is lateral trunk bending. And you can see that here. The shoulders have translated the weight across to the prosthetic side without the hips moving. We have lateral trunk bending. And you can see that back pain is going to occur there quite easily due to the shear forces created in the lumbar spine when he's laterally trunk bending. Now, the causes of lateral trunk bending in amputee gait can be broken down into weight-bearing issues or lateral pelvic shift issues, or a combination of both. And I've listed them here in this slide. The causes in the red are due to amputee issues, and the causes in the grey are more prosthetically related. So if we look at the weight-bearing problems, they can be simply because the amputee is a primary user and using a prosthesis for the first time. They might have, or probably will have, a tender stump and an inability to weight bear fully on that side. Prosthetic causes can be prosthetic length, whether it be too high or too low, a high medial wall causing pain in the groin, and the amputee is therefore unable to weight bear on the prosthesis. Other pain from the socket, or especially for the transfemoral amputee, distal lateral stump pain. If we look at problems with lateral pelvic shift, these can be related to, in the amputee and their anatomy, of a short stump, a flabby stump, with lots of residual tissue, so that the femoral remnant is sort of wobbling around in there like a spoon in pudding. They might have poor balance, weak abductors, in conjunction with poor core stability. They may have a lack of upper body rotation, which also prevents lateral pelvic shift. They may have an abduction contracture, or looking at the prosthesis again, they may have a poorly stabilised femoral remnant, pain, or a wide ML diameter in the socket. If we look at normal gait, we can see that the pelvis tracks laterally toward the weight-bearing side, and lateral pelvic shift reaches its maximum just after mid-stance. And so when we walk in forwards direction, the pelvis goes through a sinusoidal wave, like so. Control of that sinusoidal wave towards the weight-bearing side is via the gluteus medius on the weight-bearing side. The glute med contracts to hold the pelvis stable and level as the pelvis tilts down slightly as the swing leg tracks through its swing phase. Rotation of the upper body in opposition to the pelvis helps to balance the body weight over the stance limb in conjunction with core stability and a bit of quadratus lumborum activity to keep the pelvis elevated and avoid a Trendelenburg gait. Now we need to look at the reasons as to why the effectiveness of the glute medius is going to be decreased after amputation. And I'm particularly looking at the transfemoral case here because it's exemplified, being further up the tree. But firstly, and most of all, is destabilisation of the lever's contact with the ground, obviously, because the anatomical leg is missing, has been replaced by the prosthesis, which needs to be stabilised around the stump. So effectively, we've added another joint into the leg, and that's the joint between the stump socket interface. So there's going to be extra movement happening in there, which works to destabilise this lever that the patient has to weight bear on. And so with that destabilisation, we have motion of the femoral remnant within the socket. So as the abductors or the glute med tries to work, it tends to abduct the femur within the socket, and particularly if that is not stabilised well, that will decrease the effectiveness of the glute med even further and promote problems with lateral pelvic shift. We may have just weakness of the muscle because it hasn't worked in this way with weight bearing from surgery during the pre-prosthetic fitting phase. And in all likelihood, we have decreased core and abdominal strength on that affected side due to the decrease in weight of that side for the past 3 weeks or more prior to prosthetic fitting. Also decreasing the effectiveness of the glute med after amputation is the sectioning of the adductors. This means that the abductors are able to pull more strongly into abduction. The adductors are not wanting to work as much because they've been sectioned. And we have difficulty in achieving that nice adducted position within the socket and a lengthened position for the glute med to work in. The abductors may become shortened and overactive due to constant positioning of the stump in abduction, and this is common because of non-weight bearing in that initial healing phase of rehabilitation. The patient is often in sitting and abduction, so hip flexion and abduction a lot, causing an flexion abduction contracture, and also habit patterns of putting their stump up on crutches and so on, which we want to avoid shortening of that muscle, and then we cannot put it in the correct position within the socket and align it properly in the prosthesis. So if we look at the action of the abductors in stance phase, for maximal effectiveness of these muscles, we need a lengthened position by a good degree of adduction within the socket and stabilisation, the lateral wall of the femoral remnant. We can see in this side over here, if we don't achieve that, the muscles are going to be shortened and unable to work in their position of mechanical advantage. The abductor muscles in this position of mechanical advantage need to work eccentrically, which means they are producing a lengthening contraction for control of this slight pelvic depression that happens during intact swing. And they also need to be unimpeded by pain in the socket to get a maximal contraction as well. Other factors contributing to lateral trunk bending in the amputee gait are an associated loss of upper body rotation in opposition to the lower limbs. Now just think back to the beginning of the webinar when you tried to weight bear on the left-hand side without shifting your pelvis. Your shoulders translated to the left as well without any rotation. So imagine now we're going to get that pelvis translating laterally and we're going to impose shoulder rotation on top of it, as is the case in normal gait, to balance the body of the amputee over the prosthesis so that you can see here the pelvis has translated to the weight-bearing side, but the upper body has rotated in opposition to the pelvis to produce better balance on the prosthetic side. So when we look at someone who's an amputee walking who has inadequate lateral pelvic shift, this is what their gait looks like. The pelvis has shifted away from the prosthesis and the shoulders have gone excessively to the prosthetic side. With an optimal gait, we have a pelvis that has shifted to the prosthetic side and an upper body that has rotated in opposition to that. So the big question is, how do we go from this to this? And that's the point of today's webinar, looking at the implications for the clinic in decreasing or preventing lateral trunk bending in amputee gait. And the things that we'll be going through are postural re-education, looking at stretching of shortened muscles, abductor strengthening is a very important one, and looking at how we're doing our gait re-education to integrate improved activation of the hip and core muscles into the gait pattern and using our correct aids properly. Abductor strengthening exercises are pretty easy to produce. We just need a piece of TheraBand and abducting the stump and the prosthesis in between the parallel bars. Now it's a concentric contraction as we abduct the leg. The important part of this exercise really is the return journey of the leg, because if we control that against the stretch of the band, we're going to be strengthening that eccentric contraction that we really want when the patient is weight bearing. So it's a very important part of the exercise. It's really not the pushing out. It's going to be the control on the way back in. And usually you'll find they're much worse at controlling that contraction as the leg tracks back in towards the intact side. We need to look at the muscle synergy that has to happen in order for lateral pelvic shift and weight bearing to happen on the prosthesis. We need to choose exercises that encourage weight bearing, such as destabilising the intact limb that we've got here on a small ball, If we do this in front of a mirror, we can posturally re-educate the patient. I'm sure you've all noticed that when someone's wearing their prosthesis, if you encourage them to weight bear even evenly on both feet, they will report that they feel like they're leaning too far to the prosthetic side. And this is because in the initial phase after amputation, they've effectively become one-sided and they're used to having their centre of gravity over this side of their body because they've only got the one leg to mobilise with or to stand on. So when they're required to move their centre of gravity back to the middle, they feel like they're leaning too far to the prosthetic side, and this inhibits them in their ability to laterally pelvic shift onto the prosthesis. So by giving them some visual feedback, looking in a mirror, they can see where they are in the middle, and then they can see where you want them further over to the prosthetic side for weight bearing and preparation in stance phase on the prosthesis. So we're wobbling the ball here, forwards and backwards, 10 to 15 oscillations in 3 sets. And I often tell them to do this first thing in the morning because it reminds the muscles how they've got to work to translate the weight onto the prosthesis. It's a good little wake-up, if you like, for getting all the muscles working together in preparation for walking for the day. If we look at strategies for increasing weight bearing on the prosthesis, we can use things like bathroom scales under the prosthetic side with a matching block under the other side so that the patient can see how much weight they're actually putting down through the prosthesis, because in the initial stages of gait training, they don't really know how much weight they're putting down there because they're using the support of both their hands. So we weigh them initially, see how much they weigh with their prosthesis on, and obviously our goal for the end of gait retraining is to put the entire body weight down through the prosthesis. This is a form of biofeedback, and we can use other forms of biofeedback that perhaps make a sound when the patient transfers their weight onto the prosthesis. We need to give them visual feedback, as I've mentioned, in the mirror, so that they can see themselves transferring the weight with the pelvis and the shoulders in line so that they get shoulder over hip, over the foot of the prosthesis. We then progress this by decreasing contralateral hand support. So the next move is to remove the contralateral hand off the parallel bars and move it onto the same side to help get the weight onto the prosthesis. And then we can apply some resistance, as I'm doing here through the hand, to try and push them off the prosthesis and getting them to push back against me. They will feel that they strongly put weight down through the prosthesis. You can then progress this for someone using an MPK, for example, to do squatting exercises and sitting activities, sitting to stand activities, to get more weight through the prosthetic side and get their knee functioning better for them. Interspersed with their strengthening exercises, I will often use sideways walking drills. Sideways walking drills are really good for developing balance and strength up here in the abductors, concentrically and eccentrically as they're walking sideways, without having to worry about knee control. So it's a good strengthener, confidence builder and balance improver all in one. And I'm a girl who's all for bargains, so 3 for 1 is a great bargain for me. Lots of sideways walking initially, and also further down the track with more advanced drilling with crossing of the feet, as we can see here, because it gets the hip muscles working in an increased range of movement with a decreased base of support so that more balance is required. Notice here that any help he's using or any hand support is with the same hand as the prosthesis to get maximal work out of the prosthetic side. Also with advanced drilling, we've got the walking the line drill, where they must hit the line every time with the prosthesis, because as you're aware, any little misplacement of the foot will cause an upset imbalance for the amputee, so they need to place the foot the same every time. And then further down the track in their gait training, I'll get them to walk heel to toe down the line, because again, that increases the work required by the hip muscles on the prosthetic side in conjunction with the core. And you'll notice here he's employing really good arm swing and upper body rotation to balance himself over his narrowed base of support during gait. If we look at the way we train people in the initial stages, we can do this much more effectively if we look at how we're getting them to support themselves with their hands while they're learning to weight bear on the prosthesis. So in this case here, the arrow represents the amount of relief he's receiving from his hand support for the hip abductor muscles on the prosthetic side. So it's quite significant on this side in comparison to this photo, where we have a much smaller amount of mechanical advantage relief for the abductors on the prosthetic side, where you can see he's actually had to shift his pelvis and use the muscles to control himself, okay, by using the same hand on the prosthetic side. So if we're always taking so much weight away from the prosthesis and giving the abductor muscles this much assistance, they're never going to get strong enough to produce a good gait with a hands-free gait pattern. We need to get the weight onto the prosthesis and the muscles working strongly in order to be strong enough to support the full body weight in the correct position of shoulder over hip over prosthetic foot. This translates to when we are using walking aids as well. As you can see here, holding the stick in the opposite hand to the prosthesis only works to take the weight off the prosthesis, decrease the amount of lateral pelvic shift that he achieves, and ultimately offer an excessive amount of support and mechanical advantage relief for the gluteus medius on the prosthetic side. Whereas if we place the gait aid in the same hand as the amputation or the side of the amputation, we only get a small amount of relief for that glute med. We get optimal weight shift and lateral pelvic shift to the weight-bearing side, shoulder over hip over foot, which is what we're trying to achieve in an ultimate gait pattern. This, however, does produce the one-stick dilemma, and anyone who's tried to do this will get the complaint from the patient that that feels really awkward and uncomfortable. And that's my point. It's much harder to walk that way. It feels awkward because you're not getting that upper body rotation, so it's going to be really easy for me to take that stick away. And the way that I go from here to here is via a technique called facilitated walking. And what it is I'm getting the patient to contract their core and glute muscles strongly, focus on just walking and taking even steps with their feet. And what I'm doing is cueing upper body rotation with my hands. Instantly you will feel that the patient produces a much more balanced gait when they're walking. Because you're adding in that rotation, they will be balanced over the prosthesis and they'll be able to walk much more effectively between the parallel bars. It's a really effective technique for getting rid of that stick. Other methods of reinforcing that upper body rotation are throwing and catching. We're always looking for weight bearing evenly on the prosthesis, not transferring weight away from the prosthesis as we're throwing and catching to the side, doing some footy passes here, rotating over towards that prosthetic side. We can use a medicine ball and do rotating drills, again, while weight bearing optimally on the prosthesis. It strengthens the core, strengthens the abdominals, particularly the obliques, which are going to assist us in rotation of the upper body. We can add resistance, so a resistance band, put the patient in prosthetic mid-stance, the intact leg behind them, and rotate the shoulders in opposition as they would during walking. So we can do that 15 reps in 3 sets to strengthen that motor pattern. We need to monitor weight bearing and posture during all of these exercises. Another good one is boxing. Again, I'm monitoring where the weight bearing is and notifying the patient that as soon as the weight comes off the prosthesis, stop the exercise, move the weight back onto the prosthesis. The prosthetic foot mustn't move during these exercises. And if you are looking at doing that, if the patient's looking at doing that, that's feedback. As soon as that foot moves, it means they've taken weight off the prosthesis. And then he's doing cross jabs here to produce alternate upper body rotation while producing a force. So it's a much more advanced exercise. It needs much more core stability as well. So it's teaching him to switch on his abs more strongly and contract his glutes to stay and keep his center of gravity in the middle of his feet. We can also then reverse the gloves and we can get him to block, so he then has to accept force in that way as well. So we're actually getting a lot more dynamic balance in that he can be balanced on both legs with equal weight bearing and stability, and he's able to produce force and accept force. So you'll have a much more confident prosthetic user who has much better balance and is able to maintain the weight on the prosthesis when there's something different happening in their environment instead of unloading the prosthesis and becoming unsteady. Also looking at reinforcing the gait pattern with rotation during gait, we can pop some small weights in the hands, and that just emphasises for the client. They can feel that rotation happening much more because the weights take the arms through their natural swing phase as they concentrate what's happening around the pelvis in their abs and their glutes. We can use medicine balls. This is much harder. They can walk with rotation. The medicine ball goes over the foot that's in front, so that causes upper body rotation in opposition to the foot that is placed forwards. So putting it all together, we've got our indicators of an optimal amputee gait pattern, which includes all of our ease, our even step length, which will be much more even when we get better lateral pelvic shift and weight bearing through the prosthesis to allow time for a better swing phase of the intact leg. We have extended hips, an erect trunk, and we're using the entire foot and achieving a good toe-off position, especially important for the use of flex feet to harness our energy return, and also for the above-knee amputee to achieve a really good end-of-stance toe-off position to disengage their knee joint prior to swing phase. We have an even arm swing, and as we've seen from this webinar, we have a pelvis that shifts laterally towards prosthetic stance, and lateral trunk bending is minimised by the inclusion of upper body rotation. That's all I've got for you today.